For this video, we will continue our discussion of anemia that we started in Block 4. But in Block 4, we focused on anemia in CKD, where we introduced this regulatory loop I'm illustrating here, where in non-CKD patients, when hypoxia is sensed, the transcriptional brake on erythropoietin in the kidneys is released, and the production of erythropoietin increases in the kidney to then circulate to its intended target in the bone marrow. And remember, erythropoietin is a hormone that is responsible for promoting the survival, proliferation, and differentiation of erythroid progenitor cells in the bone marrow. This will ultimately increase red blood cell production to increase the oxygen transport capabilities to correct the H&H and hypoxia. In the anemia video in Block 4, we also introduced recombinant erythropoietin agents, also known as erythropoiesis-stimulating agents, or ESAs, like epoetin alpha and darbepoetin alpha, which essentially supplement the erythropoietin as a treatment option for some anemias. However, in this video, we are going to focus on iron-deficiency anemia and the appropriate treatment options for this. But I want you to keep in mind that these ESAs, even though they are not appropriate for this iron deficiency anemia indication, and this regulatory loop, cannot work to correct a low H&H if there is not sufficient iron available to make new red blood cells. So before we dive into the causes and treatments of iron deficiency anemia, let's go over iron absorption and metabolism. So from the diet, a small amount of iron is absorbed in the small intestines. The iron in its ferric form must be converted to its ferrous form via ferric reductase before it can then be absorbed by enterocytes. And the acidic environment helps with its absorption. So ferrous iron is then oxidized to its ferric form in the enterocyte by hephaestin, and then transported into the systemic circulation via the membrane transporter ferroportin. Ferric iron is eventually bound to transferrin in the circulation, where it is transported to the bone marrow, where the two ferric irons and transferrin complex interacts with the transferrin receptors on erythroblasts and then undergoes endocytosis. Once inside the erythroblast, it is used for hemoglobin synthesis to eventually form mature red blood cells. So the majority of the body's iron is in the form of hemoglobin in functioning red blood cells, and after about 120 days, the red blood cells die, and the components of hemoglobin are broken down and processed by the spleen, and then iron is stored in the body, like in the liver. Some of the stored iron will be released from these areas into the systemic circulation when needed, beginning the loop again. And keep in mind, this is pretty much a closed loop, so there really isn't a way for the body to clear iron. Instead, almost all of it is being constantly recycled. So there is a small amount, like I said, absorbed from the diet, and this is balanced by the small amount lost from the sloughing off of epithelial cells from day to day. Moving to our next slide. The absorption and release of stored iron is tightly regulated to match the body's needs. However, if there is some sort of prolonged imbalance, this can eventually lead to iron deficiency. And without sufficient iron, there will be a lack of red blood cells and a drop in the H&H and signs and symptoms of anemia. So in order to treat the anemia, the cause of the iron deficiency must be corrected. So for instance, blood loss due to an acute hemorrhage or chronic bleeding can lead to anemia, which can be corrected with transfusions until the bleeding is corrected. This cause and treatment will not be our primary focus for today. So inadequate iron intake or absorption can lead to anemia, which can be corrected with iron supplementation, and we will be focusing on iron supplementation options in this video. Again, we discussed our erythropoiesis stimulating agents before, but these agents are not appropriate for this indication. So first we will discuss our oral iron supplement options, which is usually in the form of ferrous sulfate, and this is a very commonly prescribed agent, but there are other forms of oral iron out there. So ferrous sulfate is already in the absorbable form so that it can be absorbed by the enterocytes via the major iron transporter DMT1 and just fed into this pathway to be used for hemoglobin synthesis and red blood cell production in the bone marrow. And the goal here is just to reestablish iron stores in the body. And PO supplementation is the mainstay of therapy. But this should only be initiated after confirmed iron deficiency. Because remember, this is a closed loop. So if you overshoot the iron, this may lead to hemochromatosis or iron overload. So patients should be counseled that it may take a while to restore iron stores and that GI side effects like nausea and constipation are very common and commonly a cause of non-adherence. So iron is pretty poorly absorbed, especially when taken with food, but many patients find this minimizes the nausea, so this would ideally improve adherence. So if needed, this can be done. So counseling on expectations and a bowel regimen if needed is essential to promote adherence. Another thing to keep in mind is that this is a cation. So it's going to chelate with a number of drugs, like some antibiotics, for example, so they must be separated by a few hours if the patient is on both of these kinds of agents. So these are really the primary concerns of oral iron. However, parenteral iron is more complicated, which is why it is not first line. So in patients unable to tolerate oral iron, or for those that do not respond because they may be unable to absorb it, like in celiacs and Crohn's disease, parenteral iron is the next option. So there are several parenteral iron options. Most are given IV, like sodium ferric gluconate complex, and one example that is given IV and IM is Iron-dextran. The primary difference between oral and parenteral iron preparations, besides their route of administration and GI side effects, is the risk of anaphylactic reactions that comes with these parenteral agents, making them much more risky to administer. So Iron-dextran, for example, requires a test dose and monitoring of the patient for at least 1 hour prior to administering the full dose of Iron-dextran. And this risk is increased for those with other drug allergies or those patients on an ACE inhibitor. And resuscitation equipment and epinephrine should be on hand for the administration of this particular agent. So these recommendations and severity of reaction does vary from agent to agent, but there are also a number of other serious side effects that come with these parenteral iron options. So I won't take the time to go through this long list, but these adverse drug reactions are the primary reason oral administration is preferred over parenteral administration. But counseling is key to promote adherence to these oral regimens so that these more risky agents are not necessary unless there is an absorption issue. So moving to the next slide. So the primary goal of this video was just to compare and contrast the pharmacology, particularly the adverse drug reaction profiles of oral versus parenteral iron supplementation options, to highlight the importance of patient counseling and the promotion of adherence when it comes to treatment regimens for iron deficiency anemia.